Hey guys, my name's Mari Johnston. I just joined the faculty at Ohio State, so I'll be working on Wednesdays in the clinic with some of you. So Miss Messina just wanted me to put together a little video going over what's inside a pediatric office that is kind of different than a general office, just since you guys don't have the opportunity this semester to go in and observe a pediatric office. So the reason she has me putting this video together is because I actually work at a pediatric office right now. So I work at Herring Pediatric Dental in Dublin, Ohio. I've been there for about a year now. So for the past couple weeks, I've just been taking videos of different things that are seen in a pediatric office compared to a general practice. So I hope you guys kind of enjoy this video and learn a lot about what's inside a pediatric office. This is an example of a hygiene suite we have in the office. So this allows us, if we have a big family, to see them all in the same room side by side. And then we also have two individual hygiene rooms. So this is a close-up of one of the sides of the hygiene suite. So each area that a hygienist works in, they will have two computer monitors. One, we will always have the patient's chart up, and then the other side will have the schedule up. So typically in a regular day, we will run 4 hygienists and 2 doctors. 2 hygienists will typically be checked by one doctor, and then the other 2 will be checked by the other doctor. It's always nice having the schedule up so you can kind of keep track of where everyone is and who needs an exam or if anybody is running behind. But as you can see, everything looks pretty typical to what a general practice would have. Nothing is super different with our hygiene workstations than in a general practice. Each hygiene suite also has an x-ray unit in the middle for each side to be able to use, and then also the individual rooms have their own individual x-ray unit just so we can stay in our room and get our x-rays taken. So this is an example of the doctor's suites. They are pretty similar to the hygiene suites. They just have an x-ray unit on each side, and they also have TVs on the ceilings for the kids who are getting restorative work done. Really just helps keep their mind off of what's going on. They also always have their nitrous out and ready. Now that you guys have seen an overview of our office, I wanted to highlight a few things. So the first thing are x-rays. So we do have sensors in the office, but since we do work with little kids, some kids can't handle them or tolerate them, so we have phosphor plates. So this is what a phosphor plate looks like. We have a size 0 and a size 2. We label them based on if they're for a bite wing or PA, and we also date them because we do replace the phosphor plates once a year. They are also reusable. So they have wrapping over them, and after you take the x-ray, you can unwrap them and then rewrap them and reuse them. Now, we can connect tabs to them. These tabs help hold the plate in place when it is in the child's mouth. They are a lot thinner, so it's a lot easier for the child to tolerate. With the phosphor plates, we can also use snap arrays. Miss Messina has told me that you guys have seen snap arrays and have kind of played around with them in class. This is the processor that we use, so we will run the phosphor plates through these to help transfer the x-ray into the computer. Typically with this, the lights will be off because if it is exposed to light, then the x-ray will disappear. This is our x-ray room. Like I said, the lights are usually off. So in this room, we also have our pan machine. We take the pan to evaluate for phase 1 or phase 2 ortho, and then also to evaluate for wisdom teeth. Now, also for x-rays, we do start taking x-rays on kids around 4.5, and when we take their first series of x-rays, we will take 2 bite wings and 2 PAs. So the PAs are technically occlusals of the top and the bottom, just so we can check out their front teeth and see their adult teeth that are growing and make sure they're not missing any or see if they have any supernumerary teeth. Now, we will take x-rays on kids if they are younger, just depending on their behavior. If we know they can tolerate it, why not get them and kind of just keep an eye on their teeth, make sure there are no cavities. But it's very rare that a kid younger than 4 will tolerate it. Sometimes 3-year-olds will, but it really just depends. Now, when I worked in general practice, we didn't start taking x-rays on kids until they were 6 or started losing their first teeth. So it was very new to me taking x-rays on a kid younger than 6 when I started working in pediatrics. But now that I do it, it is so beneficial just to see if there's missing teeth, if there's supernumerary teeth, and just to kind of check on their adult teeth and make sure they're forming correctly, and also obviously to make sure there are no cavities. Another topic I wanted to highlight are sealants. So we do place sealants at my office when the patient gets their 6-year molars in and then their 12-year molars in. Now, hygiene will majority of the time see and place sealants. However, we do not get an assistant. We do them all on our own. So if we know the kid is going to struggle or has a really bad gag reflex or is super nervous, we will schedule them with the doctor because they have an assistant, and sometimes the kid will just do better with the doctor. Now, for sealants, if it's just sealants, we will get 30 minutes for the appointment, but if it's sealants and a cleaning, we will get 60 minutes. Now, I'm going to show you guys a couple of things that we use at the office to help us just since we don't have an assistant. So one device we have to help us with sealants is called an IsoDry or a dry shield. This is my go-to. So what it does is it connects to the high-speed suction, and it has holes in it if you can see there, and it just helps suck everything in so we can keep the teeth isolated. It also has a bite block on it so it can help keep the child's mouth open. However, with these, they are kind of a mouthful, so any child who has a bad gag reflex or a small mouth sometimes can't handle these. And if that ever happens, we have something else to help us. So these are Garmer's holders. They're called cotton roll holders. So what they do is on each side, you connect cotton roll to it, and it helps isolate the teeth. And then the bottom part connects to the chin, and we can tighten it to help hold it in place. So this is a lot better for a child who can't tolerate the dry shield. Now, another thing about working in a pediatric office, you have to be aware of when we need to evaluate the child for ortho. So nowadays they do the phase 1 and phase 2 treatment, and you must know when the child is ready for each phase. And typically what we'll do is we take a panoramic image like shown, and we'll have the doctor kind of evaluate and send to the orthodontist if needed. So for phase 1, what we look for is when they lose the 4 front teeth on the bottom and on the top. Sometimes we'll take the panoramic image before the upper laterals have erupted. That's if the child has a crossbite. So after we take the pan, the doctor will come in and evaluate, see if the teeth have enough room to come in, and if they don't, that's when we will refer to the orthodontist for phase 1 if the child were to need expansion. Now, after that happens, we have to be aware of when they'll be ready for the second phase. So that'll happen. We take the pan. As you can see here, this child has lost all of their baby teeth, and that's typically when we'll take the pan to evaluate for phase 2. So again, just like phase 1, we'll take the pan, and then the doctor will come in and look at the child's bite, see if there's a crossbite present, and then also see if they are class 1, 2, or 3 tendency. If they're class 1, typically the patient doesn't necessarily need to go to the orthodontist. If they do, it's mainly just for aesthetics. But if they had that class 2 or class 3 bite, we want to send them over to the orthodontist. Being in a pediatric office, we also use a lot of behavioral techniques. Unfortunately, with HIPAA, I can't record myself with my patients using behavioral techniques, but I will attach some videos to this just so you can kind of see how behavioral techniques are used. So just a few that we use in the office, probably the number one is tell, show, do. This works really well on younger patients if it's their first time visiting or very nervous patients. So it essentially just lets them see everything before it's actually done, One of the main things I do with Tell Show Do is some patients are scared of the polisher because of how fast it goes and the noise of it. So I'll let them feel it with their finger before I go in and polish up their teeth. This pretty much helps them see that the polisher is more ticklish than anything and kind of more funny than scary, and that'll really help and kind of make them excited to get their teeth polished instead of scared. I'll also show them all the instruments I'm going to use. Sometimes I don't even show them the scaler just because of how pointy it looks, and most patients, if they're young and already scared, they're going to be scared of the scaler. So I'll show them the mirror and the Explorer, and I'll say, oh, I need to use the mirror to check out your back teeth. I call the Explorer the tooth counter, and I show them how it's not pointy or like it doesn't hurt or anything. And then after I show them that, I'll kind of go in their mouth with the scaler and they think it's the Explorer. Another behavioral technique we use in the office is positive reinforcement. I'm sure a lot of you remember going to the dentist when you were a kid. You would get a prize at the end. So that is our main driving factor in whether or not the appointment goes well or not. So if a patient is misbehaving, if you always mention that prize, and if we kind of behave and get through everything, they'll get their prize, or if they continue to misbehave, they won't get their prize. And usually if they hear that they're not going to get a prize, they'll cooperate and get what you want done. Another thing that I never really have seen before until I started working my pediatric office is we do IV sedation. So we have an IV sedation once a month. This is when our main doctor, Dr. Herring, he works with an anesthesiologist, and he will essentially, the anesthesiologist will put the child to sleep, and Dr. Herring and his assistant will get all of the work done. If that's typically it's on patients who are they have very poor behavior and they have a lot of dental needs. So these are typically younger kids. I think majority of our patients in IV sedation are 6 or younger. So these are patients who have a lot of cavities done, and when they are in for their hygiene appointment, we couldn't get their cleaning done just because of their behavior. So Dr. Herring will get it all done in one appointment while the child's asleep. This just is super beneficial, especially for kids who would not be able to get dental work unless they were asleep, because sometimes nitrous just isn't enough. So I thought I love the IV sedation days. It's super interesting getting to talk to the anesthesiologist, and I just love kind of working those days because I love seeing the whole process. Working in a pediatric office, we also use a lot of different words for different dental items. Like for the suction, I always call it the straw, and for the air water syringe, I always call it the water gun. These are more fun names, and kids get excited to use them when we call them these. Another thing is some kids are scared of the lead apron just because of how heavy it is. So I always call it a blanket so they can associate it with something at home and something cozy, and then they're more willing to put it on. There are a ton of other words we use for other dental procedures. One thing is for sealants, we call them stars. And usually kids become less scared of sealants when we call them stars on their teeth, just because stars are super bright and super cool, and they're always more cooperative when we call them. In our office, we also see a lot of new patients. So usually I see kids coming in for their first appointment when they are 3. However, sometimes we do recommend bringing the child in earlier. This is really if parents have a concern, like they fell and hit their tooth, or if this is their first kid, if we could bring them in early so we can talk to them about oral hygiene and how to best take care of their child's teeth. Now, typically when the patient comes in for their first ever appointment, majority of the time we do spend it talking to the parent. So we talk to the parent about our office, all the services that we provide. We talk about how they are taking care of their kids' teeth at home. We give them hygiene suggestions on how to better care for their child's teeth. But the number one thing we talk about with parents when they bring their kid in for the first time is nutrition. So we always bring up the fact that the frequency of snacking is actually the number one cause of getting cavities, and this usually will surprise patients or patients' parents because they figure that as long as they're brushing and flossing, then that's all they really need to do, and that nutrition doesn't really play a factor. So we have a tooth snack guide that one of our doctors, Dr. Joel, who's actually a graduate of Ohio State Hygiene and Dental School, he put together, showing snacks that aren't likely to cause cavities, snacks that are kind of likely to cause cavities, and then snacks that are the most likely to cause cavities. So this is a nice tool for parents to take home so they can kind of limit their child's snacking. And we always discuss keeping 2-3 meals and 2 snacks a day to limit the frequency of snacking. Now we also have a lot of families that we see at our practice. So typically we will talk to the parents if older sibling comes in and younger sibling hasn't come in for their first cleaning yet. We'll talk to mom or dad when their older sibling comes in and say, hey, if you want to bring like little brother or little sister in next time Johnny gets his teeth cleaned, we can kind of give them a ride in the chair and maybe see if they'll let us count their teeth, just to kind of ease the patient into the practice and let them kind of see what a dental office has, just so that when they actually come in for their first cleaning, they aren't as scared because they've already been in the chair before. They've already had their teeth cleaned. We see a lot of success with this, and we always suggest to parents bringing in little brother or little sister. Now, also in hygiene schedule, we see a patient every 30 minutes. And sometimes this isn't necessarily just cleanings. Majority of it is. We also, like I kind of discussed earlier, is we will do sealants. But sometimes we also get emergency patients put into our schedule. This doesn't happen a whole lot. It really happens if the doctors don't have any room on our schedule or on their schedule and the hygiene do. So if this ever happens, they always write an appointment. The front desk always writes an appointment note in and why parents are bringing their child in, what's wrong or like what's going on, so that we know going into the appointment. And typically how that goes is we'll bring the patient back, talk about what happened or what they're worried about, and 9 times out of 10 we'll take an x-ray of what's going on. Usually a lot of our emergency cases are the child fell and hit their tooth and mom and dad are worried that something happened. So with this, we will take an x-ray of it and kind of see what's going on, and then have the doctor come in, look at the x-rays. We'll kind of give them an update about what had happened, what mom and dad's worry is, and then we'll go from there if treatment is needed or if it isn't needed. I just wanted to end this video going over some of the things I love about working in a pediatric office and some of the things that I don't love as much. So I would say the thing I love the most about working in peds is that there's no SRP. I didn't mind doing SRP so much when I worked in general, but sometimes I was finding that at the end of the day, my hands are really hurting. So you don't really have to deal with that in pediatrics. You do get some kids that do have a decent amount of calculus, but nothing compared to having to do SRP. The other thing I love is obviously working with the kids. That's why I am in peds. I think kids in the dental office just make everything so much more fun. They're always just there to have a good time. They are always such good patients. Yes, you do get those misbehaved ones, but honestly, that doesn't happen as often as you would think. The kids are always there. They always love talking to you. I also love talking with the parents. It's fun still getting to be able to have an adult conversation while also working with the kids. My coworkers are also super awesome. Like, everybody there is like my close friend. Unfortunately, there are some things that I dislike about working in a pediatric office. The main thing that I don't like as much is the time restraints. So we see patients every 30 minutes and we work 8:30 to 5. So essentially my day is in 30-minute increments. It gets exhausting sometimes, especially if you do have those difficult patients. And say the dentist is busy doing a restoration and can't get up at that very moment. You could be waiting 15-20 minutes for an exam and then run into your next appointment. So that is the biggest frustration about working in pediatrics. But honestly, that's really the only thing that I dislike. I hope you guys enjoyed this video and were able to learn a little bit more about a pediatric dental office. I have attached some videos of stuff I wasn't able to include in this. I included a video about placing the IsoDry for sealants and also using the cotton roll isolation for sealants. And then I also attached some videos going over behavioral techniques that I wasn't able to show you guys just because of HIPAA. If you guys have any questions, please feel free to reach out to either me or Miss Messina. We are more than willing to answer any kind of questions that you guys have.